So good morning, everyone. My name is Dustin Paul. I'm a general pediatric neurologist and a pediatric neuromuscular specialist at Penn State College of Medicine, and I'm going to be talking about epilepsy and NCBRS. I have no financial disclosures, so the learning objectives for this lecture is going to be talk about and be able to discuss the pathophysiology of NCBRS. A lot of that has already been covered. Then the neurologic manifestations of NCBRS and epilepsy treatment options for NCBRS. So I'm going to start out with my patient who has NCBRS. So 11-month-old sweet little girl came to the hospital with concerns for seizures. This little girl had a cry that was very abnormal, tensing of the arms and legs, eye deviation, the eyes going in one direction with some lip smacking, and lost consciousness, impaired awareness, and was falling asleep afterward. So history, very suspicious for seizures. On exam, she was severely hypotonic. Whenever I lift her up, she would just kind of be very floppy. And had dysmorphic features. And so her diagnosis was NCBRS. So in 1993, Dr. Nicolaides and Dr. Baraitser described a 16-year-old British female. That's when this was first described. There are less than 1 in 1 million people affected, or less than 200 people worldwide that are affected with the disorder. So some genetic mechanisms, it's a de novo variant in SMARCA2, which is on chromosome 9p. So this encodes the ATPase complex of the SPU or SNF-BAF chromatin remodeling complex. Most of the genetic mutations are missense mutations that are clustered around that ATPase domain. That's what causes this disease. Now, as Stephanie said in the lecture previously, there's an area outside that causes an intermediary phenotype. So it causes a dominant negative effect, impairing chromatin remodeling activity. So this is SMARCA2 on chromosome 9q, and most of the problems that we see is here in this ATPase binding domain. Less severe is in this domain over here. So this SPU SNF complex controls nucleosome positioning and transcriptional regulation. So DNA to RNA to protein, that DNA to RNA, that is where the dysfunction or problem is arising. In the mutant BRM, this chromatin assembly that leads to this transcriptional regulation, dysregulation. That is where the problem arises. So it affects genes in neuronal or your brain cell differentiation, synapses, this is brain cells synapsing together, and their plasticity, being able to learn. And as we learn, the plasticity of your brain cells, your neuronal cells. So this leads to problems in dendritic growth. So the outsprouting of your brain cells, your neuronal cells, signaling from one cell to another, and then the network formation of all your brain networks for all the activities that we need to do. So from genotype to phenotype. So SMARCA2 is on chromosome 9p, and then it causes a dominant negative effect. It affects chromatin remodeling that alters your gene transcription. So embryologically, when developing inside of mom, these mutations very early on in development causes this dysfunction. So this neuronal synaptic maturation that affects that causes network dysfunction and abnormal neurologic development. That is what's leading to the clinical manifestations that we see in NCBRS of intellectual disability, epilepsy, speech delay, and the distinctive features. So synaptic plasticity and postsynaptic density, so that's you have a neuronal cell, it sends a signal to another neuronal cell or brain cell that has to receive the signal. That postsynaptic density has been shown as well as effects on long-term memory by building long-term potential. So there's that electrical activity is important. Dysfunction of those long-term potentials goes along with what lowers your seizure threshold to cause a seizure. So some of the clinical features of NCBRS, almost 100% of the patients have some degree of intellectual disability, sparse hair, prominent interferion joints, coarse facies, epilepsy, microcephaly, and cryptorchidism or oligodontia. So I think these are some of the features, but then this is from the article. It shows both males and females, again, slight male predominance of the disorder, and then different ages as the patients are getting older, from babies to adulthood, how they transform. Then these are also the feet, some of the feet and toe abnormalities. You can see increased space between first and second digit, and larger distal phalanx. Again, this is as patients are aging, how you can see some of the features in our patients with NCBRS and how they change as they grow over time. And these are also the fingers. You can see the distal phalanx, they're a little bit wider. Now, the neurodevelopmental features of NCBRS, most notably is some degree of cognitive dysfunction. So that can be mild to very severe. Brain imaging is normal in most patients, but I'll talk a little bit more about that as we go on. Most patients are pretty happy. They want to play with us. They want to interact. They're social. They are happy in general. They have a short attention span and a high pain threshold that Dr. Nicolaides had talked about earlier. So epilepsy, reported between 60 to 70% of patients develop epilepsy. I think it's actually much higher. I think, and it can transform throughout your entire time. And then there's a variety of different seizures which patients can have: tonic, clonic, atonic, myoclonic, impaired awareness. So tonic seizures that's a part of the seizure where you're stiff and you're not able to break them. That's a tonic phase of a seizure. Then clonic is the jerking, rhythmic jerking. That's another form of a seizure. You can alternate between clonic and tonic phase of a seizure. Then there's atonic seizures. This is where you're standing up, boom, drop down, and you would injure yourself because of loss of muscle tone through your whole body. You just fall. Okay, you can severely injure yourself with atonic seizures. Myoclonic is, myo means muscle, so, and clonic is a jerk of the muscle. So very quick jerk of the muscle. Okay. Then impaired awareness and complex partial. This is where this is very difficult to sometimes diagnose, because it could be just simply staring off and not responding for a couple of seconds. That is because you're getting abnormal electrical activity spread throughout their brain, but it's not going to anything that you can visually see in terms of clonic or tonic activity. Okay, you could say, if I was staring off for 5 seconds, did Dustin have a complex partial seizure right now? So it's very difficult. That's one of the more difficult ones to pick up on. Onset for epilepsy can vary. On average, it's about 23 months of age, but then it can be very young as neonates in the first month of life, all the way up to much older in your teenage years. So it wide spectrum. So once you've, the testing that we do for epilepsy is EEG. That's where we put the electrodes, see how is the electrical activity. There's a variety, many different findings you can see. So one is generalized spike wave discharges, and that is the entire brain has spike coming out. That's usually what leads to the tonic-clonic seizures, where you see the entire body shaking and stiffening. Slow background. So from birth until 8 years of age, there's a certain electrical pattern that your brain should be developing as you're growing and developing. And if it's any slower than that, we say it's slow for that patient's age. So it's very nonspecific. We see it in many diseases, but it's a very nonspecific finding. And then focal slowing is just one part of the brain is slow. So EEGs are just a snapshot of time. So it's like you're waiting at a railroad for a train to come, or it could have already passed. It's just a snapshot. You're waiting at the railroad. Is that train going to come 1 hour, 100 days from now, or did it already pass? Did it pass a year ago? It's only a very short snapshot of time. But then it's also more important is the history of how our patients are doing. Okay, are they impaired awareness? How is their cognitive dysfunction, speech delay? Is there any regression of going backward? All of those things factor into, are there undergoing seizures that are ongoing? Imaging. So MRI brain is the modality of choice. Now there's a couple of different abnormalities which have been described. One is alterations of the white matter. There's a deep particle gray matter, and then white matter, very nonspecific. Asymmetric ventricles, that's where you have spinal fluid made, and then it can just be asymmetric. Again, very nonspecific finding. Hippocampal sclerosis is usually that's the most common cause of epilepsy in adults worldwide, and that is where you have a scar on the brain, and that leads to bad electricity coming from the brain. But in actuality, most patients, when you get a picture MRI of the brain, when it's normal in our patients with the NCBRS, most of them. So structurally, you're not seeing any abnormalities. Treatments. So first-line treatments are valproic acid, levetiracetam, or Keppra, phenobarbital, and topiramate. So in the study from 2021, valproic acid is a great choice. It's a great anticonvulsant, but there's also lots of side effects. It causes liver damage, causes your triglycerides to go up, it causes your platelets to go down, it can cause weight gain, ovarian failure long-term, so lots of side effects. So generally, what is recommended is, even though it's the #1 treatment, it works well, can you use a safer alternative? So then we go to levetiracetam or Keppra. Keppra usually does not have any side effects except for maybe aggression. So overall, Keppra is kind of leads the pack in terms of anti-epileptic choices. Phenobarbital, beautiful anti-epileptic. My 90-year-old pediatric neurology mentor from Australia loved it. So it works well, but it causes cognitive dysfunction. It decreases your IQ long term. So when you have NCBRS, where most of the patients will have intellectual disability, you don't want to add something that's going to make that worse. So that's why we try to shy away from phenobarbital if we can. We use it if there's no other choice. Topiramate also, it's good. It's used for migraine prophylaxis. I have migraines. I take topiramate, but then also it can be used at much higher doses for epilepsy treatment, and it works well. Not as common are the second line over here. So that's acetazolamide, clobazam, or the brand name is called Onfi. Valbamate has serious toxicity. Lacosamide, oxcarbazepine, phenytoin, zonisamide. These are not used as common. Not saying that they're not good anti-epileptics, but they're not as common. And in the study from 2021, they were not as common at that time. In the study, they said a couple of anti-epileptics could worsen seizures in NCBRS is carbamazepine, lamotrigine, and siltiamine. Okay, now let's talk about non-pharmaceutical treatments for epilepsy. One is ketogenic diet. So ketogenic diet, it alters how energy is being used by your brain. So it's a very strenuous to be on a ketogenic diet. It's not like the modified Atkins where you have lots of protein. No, it's a very, very aggressive treatment, not only for our patients with NCBRS and not only for the parents, but the entire family. It's a very aggressive treatment, but it does work well. You do see it does work very effectively to reduce seizures in a lot of patients. And it could be a non-surgery option for a lot of our patients. Then let's go to vagal nerve stimulator. So this is a neurosurgical procedure where you implant a device here. It sends a signal to the vagus nerve and helps to decrease abnormal electrical activity. So it's going all the time. And then if you're having a seizure, you can take a little magnet that you're wearing and you swipe it over to send an additional impulse to shut down a seizure. So, and then most patients can actually decrease their anti-seizure meds that they're taking. So it does work well. Now, there is a certain battery half-life. After many years, the batteries last longer, so you don't need to replace them as often, and it is a surgical procedure to implant it. Focal resection, if you identify a seizure focus. So if you have an area of brain malformation or you know where seizures are coming from on a consistent basis, then you can resect and cut out the part that's seizing all the time. That is one option for some patients. Corpus callosotomy. So there's a mid part of the brain here, which helps to relay information to both hemispheres. If you're having drop seizures where you fall down, corpus callosotomy is very effective. Usually once you have that surgery, those drop seizures should not come back. So in summary, NCBRS is caused by mutation in SMARCA2, causing a dominant negative effect, impairing chromatin remodeling. Most patients with NCBRS will develop epilepsy at some point in their life. Anti-seizure meds are first line, and second line are non-pharmaceutical options. So before this, a lot of people had submitted some questions. I'm just going to answer those questions now. So the first one, our neurologist said a child that was 50% behind for his age. That gap seems to be worsening as he gets older. So when you have any kind of developmental or cognitive regression, we can get concerned, are there ongoing seizures? If you're trying to learn and then you have a seizure, then that makes it much more harder to learn new tasks and progress from a cognitive standpoint. So then that is what has to be evaluated. Can you talk more about the ketogenic diet? Is it a lifetime diet or are you trying to wean off the ketogenic diet? So once you go on ketogenic diet, if it's effective and reduces your seizures and you're progressing well from a cognitive standpoint, not having seizures, some of my patients, yes, they continue it lifelong. If you come to a point, puberty is usually a time that it's like, you know what, we're having more seizures, it's hard to have the entire family as a lifestyle of this, then you might come off of it at that point. Do symptoms of neurologic manifestations of NCBRS appear all at once? Does it come from birth? So it can happen at any time. So age of onset of seizures was 23 months, but then you can see a lot of the other findings. You're hypotonic, you're not developing well, and that's usually what will seek attention then to the pediatrician, say, my child is not developing normally. And then that leads to referrals and then diagnosis. Our son had a corpus callosotomy. Could the drop seizures come back? I already talked about that. Long-term side effects of vagal nerve stimulator. So anytime you implant a outside device in your body, can it become infected? Can the wires break? Those are just surgical problems that come with it, but it's overall, it's a great treatment option. Can we identify specific areas of the brain affected by the SMARCA2 mutations? That is being done a little bit more on a research basis. So yes, that is being looked at. Can my child be having seizures that aren't seen on an EEG? Yes. So EEGs are just snapshot of time. It's the history. What I hear from all of you as moms and dads, yes, this is what is going on, and then putting it together. Can symptoms get worse with age? So can seizures progress and get worse, become refractory? Yes. Can they get better also? Yes, as well. So that's why it's pretty much constantly always seeing your neurologist on a regular basis. Other seizures and signs and symptoms or behaviors to be aware and share with your neurologist. So developmental regression, cognitive delay, going backward from that standpoint, those are important things to discuss with your neurologist. Is there an explanation or for lack of retention for learning, numbers, preschool academics, not seizure related? So yes, possibly. We know that intellectual disability, cognitive dysfunction, almost 100% of patients with NCBRS have it. So that is just a part of the disorder. What can we intervene on is, from a neurologic standpoint, is seizures and epilepsy. We can intervene on that. So we have to keep that in the background because that can be treated to potentially help your cognitive progress. What triggers violent behavior in an otherwise happy child? Could it be a form of epilepsy? Generally, violent behavior is generally not considered seizures, but it would have to be taken in the entire overall context. Again, when you have intellectual disability, cognitive dysfunction, and you can't communicate to the world your needs, that would lead to violent behaviors. So then it's just learning over time, okay, what are those violent behaviors? What is that manifesting? What are you trying to communicate with the rest of the world? Okay. Thank you for your attention. This is my family, and this is my 2-year-old son, who I couldn't bring because he wouldn't let me stand up here this long to talk to you all.